The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the February 2019 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and I'm here with Dr. Bill Toon and Dr. Kim McKenna. The study we're going to be reviewing today is entitled Best Practices in Teaching Pharmacology in Undergraduate Nursing Programs, a systematic review of the literature. And this was published, or will be published, in Nurse Education Today in March of 2019. Now, this review is paired with an article in EMS World called Research Alert, a review of original medical education research. We encourage listeners to check out this article at emsworld.com under the category of Education and Training. So thank you all for joining us today. So let's begin. We want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. A little background: medication administration is a critical skill of advanced life support providers and EMS providers, and more recently, really at the basic level provider with the administration of maybe lower risk situation medications such as intranasal naloxone, but also potentially life-saving administration of intramuscular epinephrine for anaphylaxis. Now, in the United States, the Institute of Medicine report, To Err is Human, in 1999, followed by the 2016 update 15 years later, called Free from Harm, revealed the potentially catastrophic consequences of errors in hospitals and in healthcare settings. Some of the modern studies, in fact, show medication errors are on the rise. So in a previous research alert, we reviewed another study that documented specific types of medical calculation errors among new and experienced paramedics, noting that the most frequent error, and this again comes from just medical calculations, involved conceptual errors, which is a selection of the appropriate calculation to the problem presented. So this would not be something that a calculator or a tape or a chart might solve. Now, in this study, the researchers report in their background section also that an insufficient knowledge of pharmacotherapy was a primary cause of medication error among nurses. So the purpose of the study was to examine and describe evidence-based teaching practices from the existing literature so that maybe we can find better ways from the educational perspective to attack this clinical practice problem, medication errors. So it's a systematic review of the literature that was guided by some questions. Like all systematic reviews, you have to guide by some specific questions. And these questions related to what are the teaching strategies that were taught between 2000 and 2017, so a 17-year period, that were studied and used in undergraduate nursing programs. And then what was the effect of each of those teaching strategy on knowledge and retention of pharmacotherapy knowledge and skills acquisition in terms of medication administration. And then finally, what's the effect of each of these teaching strategies on student satisfaction? Now, before we go into the study itself, we have Dr. Kim McKenna and Dr. Bill Toon on, and I thought it would be important to just kind of go over what we're looking at, a systematic review, which is looking at a number of different research studies in education. So when we're doing these, if you're an educator and you'd like to do some action research in your own institution, or you want to do some, multi-center research or get involved in educational research, then what are the outcomes that are important? So what kind of things are we looking at? Because we talk about this, national registry scores as an outcome, but what are some of the outcomes that are important? So Kim, can you start the conversation in this? Because we were talking about this before we came on.
Sure. Well, we were talking earlier that the authors used as one of the methods to evaluate the studies, they use the Kirkpatrick Framework. And in our system, I work in a system, we run about 40,000 calls in our EMS agency. And so we do both entry level and continuing education. And we were sort of trying to say, you know, you always, as an education entity, you want to justify to administration your value and your worth. And what they tend to hear are satisfaction. You know, does somebody like a class or not? But so we started looking at our continuing education in terms of the Kirkpatrick model, which looks at reaction. So first of all, did the learners like it? You know, what was their initial reaction? Were they engaged in the education? And then did they learn anything? You know, did you measure their knowledge before and after? Did they learn anything after when they do their protocol test at the end of the year? Did they retain that? But you know, in my mind, once you get up to the higher levels, where are they transferring that learning into behaviors that they're actually using on calls? And then most importantly to outcomes, are the patients doing better or are the paramedics doing better on calls? To me, that's just huge. So in our system, we were able to show that we had implemented a cardiocerebral resuscitation pit crew approach. And so we were able to show at all of the levels that we had succeeded, including the most important, which was patient survival with neurologically intact brain function after cardiac arrest. So I love that they use that in studying, in evaluating their studies, because I think sometimes we get focused on, did somebody like it? And obviously that's not the most important thing.
We can do the same for instructors too, right? So when we go to evaluate faculty, what's one of the hinge points is, okay, well, how do the students feel? You know, what did the students say? And we know that while that's important, you know, do they feel like they were learning something? Did they feel like that, you know, they learned something from a session? That's got to be weighted against, you know, did they actually learn something?
Right, exactly.
Or was this person just very entertaining?
Exactly. And then when they go on a call, are they able to transfer that learning onto a call? You know, because I mean, there's, you know, you can measure that knowledge in so many ways, and some people can regurgitate that on a test, but then can they apply it when they go out in the real world? To me, that's like a big win.
And the hard part about that, and I guess, go ahead, Bill. I was just going to pull you in here. Go ahead.
No, and I would agree, you know, everything that's been said makes perfectly good sense to me. And this is some of my challenges with a continuing education program that is presented over a short period of time. And is there a way to really know if it makes a difference? Or they're just said, hey, I got, you know, the challenge with continuing medical education versus the initial education is that people are after the almighty, I need this hour to fill in this spot, versus an agency base, you know, one that is trying to, like Kim talked about, I worked in an agency, we did the similar type of thing where we really focused on cardiac arrest, but what we did is we first set up what is our measurement and what's our baseline, so we knew from there, was the training making a difference? And it took us probably almost a year to not only get a change, but there was a cultural change that also had to take place. People had to believe that there was, what they were learning was making a difference. So that's where being able to get back to them with actual factual information about, look at this. And then also the individual stories sometimes that came out of crews. So yeah, we took and we did this, and this is the outcome we got. And then at that point, it was easy to get people to buy into the intensity. And in the particular case I'd like to say is, for example, we were reviewing cardiac arrest with about 350 providers every other month. They were on a mannequin's chest and everything like that, and doing that for a year. So there's also, is there a return on your investment? And we certainly saw a return on the investment, not only the time, but more importantly, patient outcome.
Yeah, that's, and I put up, I'm sorry if I made people dizzy if you're watching the screen, and I flashed forward to a slide that's a few slides in. But this is that in Appendix B in this article, there is the modified Kirkpatrick quality assessment model. And they're using it actually when they look at the studies that they select for review in the systematic review. But I've seen this identified in a grant. When someone's writing an education research grant, I've heard them say, okay, this is, we're going to use the Kirkpatrick model, and they say at first we're going to implement this strategy, and then we're going to look at, for the first level or the second level here, the feedback on whether the students feel they've learned something, and then we'll look at the next translational level, which is, whether or not it changes their clinical practice, and then the third, the final translational level, and here it goes up to 4A and B, into the patient outcome, into some type of, benefit. And of course, we know that the farther we go out, the more confounding variables are going to be introduced, which then brings up, how do we control for that? And that's, controls and experimental design, and that's always going to be an issue in education, as we see in this systematic review.
We started a few years ago to look at sort of the world of EMS education research through the NMC Research Committee. And very interestingly, like if you just reflecting on the articles that we pulled, most of them were at that level 2B, that knowledge and skills level, not so much on the higher levels in the Kirkpatrick model in terms of measuring success of a given program. It's hard because it's hard to follow things out to outcome, but that certainly is going to be a much better measure of whether you've been successful.
Exactly, and that comes out in this study, and let's start to walk through this study, and we can see that actually is illustrated in some of the limitations. So this is a systematic review, and their inclusion criteria were articles that were in English. So even though there were an international result, there were articles that were only in English, which limits. There's a limitation, right there. They focused on the impact of the teaching strategy, so not something that just described, although there were a few where they had some descriptions as long as they described outcomes of the teaching strategy. And then undergraduate nursing students. So this it turned out to be mostly 25-year-old or under, female students, and most of them ended up turning out to be single center too in their results, but and just going through their search strategy. So these were what you're seeing, if you're able to see the screen, is table 1, which is their search strategy, teaching strategies, pharmacology, education, undergraduate nursing, and their impact. So this is how they search the literature, 5 databases that are pretty common databases that I think most people would recognize. And then they pulled articles, and you can see in the next slide the actual breakdown of how, and this is what we typically see in a systematic review, right? So we see that they've started with their search strategy. They identify usually a pretty big number, not so much in education research, but they identified through their database research 169 articles. I don't think that they did table of contents of key journals, or sometimes in a review, they'll review table of contents also of journals, not just, go through key terms through databases. But so 169 records, and then they excluded duplicates and looked for full text eligibility. And if they didn't address certain things like that pharmacology education, or nursing students, or if it was just no empiric research, then they excluded those, and that was 70 of them. So it came down to a total of 20, and that's what they reviewed in terms of the full text of the articles. So any flags for you guys when you're looking at their methodology? And that would be the first thing I'd look at is, okay, what about their methodology? Any red flags?
Well, I think what they did is their approach made good sense, and not unusual when you do this kind of systematic review. You find so actually few articles. You may start with a lot at the beginning, but when you apply all of your steps, you shouldn't be surprised how few there really are. And that also talks about an opportunity for those looking to do research. Says, there's an opportunity here for there to be more research done in this topic area. Why I know almost every article, research article, says at the end more research is needed. Yeah. That's never without it. But when you see there's only 20 studies on this, and then you even begin to break down how many of them could you replicate, or would there be value in replicating, based upon what they wanted to do? That's one of the things I always look at. And it's small. If you think about it, there's not a lot out there talking on what they wanted to do.
No, and this is a systematic review. So you would think, like you said, usually when we do the clinical podcast, we've reviewed a couple of systematic reviews where, they start out with thousands and thousands of initial articles that hits, and then as they go through those articles, they, whittle it down to the full text review. They usually end up with, whatever number it is, whether it's, 50 or 100 or 75 or sometimes like this, 20 to review, but they usually start off with a much larger number. So I'm sorry, Kim, were you going to say something?
I was just going to say that's surprising given the importance of the topic, I think.
Yes. Although I think, again, limiting it to nursing students is one thing, although I still think it's not just because they're from a nursing department, but there is something specific about nursing pharmacology that does relate to EMS pharmacology. And I have to just relay this kind of personal experience that I had probably 10 years ago or so teaching the paramedic program. We started to have more and more residents and fellows involved in the program. And one day I had a resident that just kind of came by at the last minute and said, "Hey, can I help out today?" And I said, "Sure." They're doing, medical calculations and drawing up medications. We're giving them little problems and they're drawing up medications. And he looked at me and went, "Ooh, you know what? The nurses really do that." And I said, "Okay, how about you talked about the pharmacokinetics and the, and he's like, "Right, definitely, I'll do that." So I thought that was a really interesting thing that, and we've noticed that sort of when the students are on their clinicals, that the nurses are the ones who are carrying out the practical aspects of the administration, even though they're obtaining the order from the physician, and certainly they know the dosing and everything, but the actual movement from, the knowledge base into the practical, nurses have to kind of go all along that scale. So I thought it really applied to EMS because just from that one experience, I don't know if you've had the same experience, but I think it's more of it that follows the workflow when it comes to medication administration. The EMS follows more of a workflow of what the nurses carry out, at least in terms of skill and calculations. Okay, so the next thing that they did, and this is actually I think one of the strengths of this article, and this is one of the reasons why I liked this article and selected it. It really wasn't because of that I thought the results were so earth-shattering. As a matter of fact, I thought it was very disappointing to have so few results in terms of the strength of the studies and such an important topic. But it has some great teaching tools in it in terms of research. And a couple of the tools, one we just looked at, which was the Kirkpatrick Framework, which describes translational research. So you go from, how you can translate your educational practice into an outcome that you desire for your student and then for your patient. So that's one thing. The other thing that they also show is the biases, and I think that's on the next slide. Yeah, the different types of biases. So they do a little bit of research teaching in this article. There's a couple of things they do. One is this description of what are the different types of bias you can see in a research article, and how they looked at that within each article. They were looking for these types of bias so they could describe, okay, these are the limitations of the research that we're looking at, because as I think Bill has said it before on this, when you're looking at a systematic review, it can be garbage in, garbage out too. If you're looking at research that's not well done and you're reporting the summary of of not well done research, then what we get is not a great conclusion. So when one of those things is to look for the quality of the research. So the systematic review that they did also looked at the different types of bias within each, and then they provide like a data dictionary for that, or a dictionary of the different types of bias. And then they used also the Medical Education Research Study Quality Instrument, the MERSCI, which we've mentioned in this, either in the research alert or in this podcast, as a tool that you can use to evaluate quantitative research in educational research, medical educational research. And so that tool has, a scoring system based upon the quality of the study. So is it a multi-center? Is it a, controlled, randomized, experimental versus quasi-experimental, that kind of thing. So they used both the Mirsky and the Kirkpatrick Framework to identify, and this is a Canadian study, so they modified it to this Newcastle, Ottawa adaptation of the Mirsky, and evaluated the quality of these studies and scored them by quality. So they could see what, in general, where did, the research lie in terms of quality. So I actually really liked that. I don't know about you guys.
Yeah, I was going to say, I thought it was interesting. That was one of the best concise descriptions of bias that I've seen. And so if you were going to embark on educational research, it would really be great to have this there to kind of look for any pitfalls before you start your study. Yeah,
I completely agree. That I thought that it was just a great tool to have. And I thought, if you don't have a research text around that you can immediately refer to, this study itself has, just a number of different, helpful tools. That was one of them, the bias, or the description of bias, the Kirkpatrick model. There was another thing in here. Oh, the description of the teaching strategies. I was actually very surprised at that. I didn't put up a couple tables because they're way too busy for PowerPoint. But Appendix A describes actually the different teaching strategies. So when we get into the results, not only did they say this, we broke these down by different strategies, they actually have an area that describes what those actually are, what the actual teaching strategy is and how they're defined. And then the other thing they did is in table 3, again, too busy for a PowerPoint, was break down each of those research studies that they pulled for their review and put in their limitations and their potential for bias. So you can actually see within each one, just kind of in a glance. The only thing I really wish they would have done here was put the outcome. A lot of times in a systematic review, they'll put the studies in a table, huge, like multi-page table. And a lot of times that one thing they didn't do was put, at least as far as I could see, the actual outcome variable. I would have liked to have seen that in a separate column. So I could easily kind of look and see, okay, what did they do? How many just looked at student satisfaction? They describe it in the text, but they didn't put it in a table. And sometimes it's nice to look in a table and say, all right, which ones did like the ultimate, in quality research and which ones didn't? Okay, any other comments you guys have about the kind of methods or the way that it's described before we kind of dig into the results? Okay, so let's walk through some of these results. And actually, I just summarized these in one little slide here. So ultimately, we see this in systematic reviews sometimes. They almost always begin, I've noticed, with, well, the studies varied. Of course, if you're selecting a large number of studies, they're going to vary. It also says something, though, about research, and especially about education research, is do we have a general guide for, and do we have a center sort of for education research where we can kind of say, okay, this is what we should be shooting for. These are the types of studies we should be doing. And Kim mentioned the word action research earlier. I think that's something that we should bring up in terms of getting some multiple centers on the same page.
Yeah, it's almost like we need a PCARN group like they have for pediatric multi-center research for EMS education, just because that was a big limitation. Almost all of them are single center.
Yeah, I completely agree. And action research, I think, is just even a small group that could be like, I think we talked about this at the last NEMC conference. If we could get 4 or 5 different EMT programs on the same page across the country. And some of that is actually happening. I know that happens at the Fisdap Research Summit. Essentially, you're starting to get some people that are coming together and saying, okay, let's take this back, and then we'll run this, and then we'll meet back and see our results. So in some ways, some of that is happening, but we'd like to see more of that. So the studies varied in size, design, and outcome variable, mostly single center. So these are some, big hits to this, to our research here. The majority, again, female under 25 years old, and the length of intervention ranged. And we've seen this in education too. I've read a number of studies where they're looking at, either a scoping review or systematic review. And when they do, they say, well, sometimes they're one-day workshops and sometimes they're over 2-year periods. So that brings up a lot of issues, especially when you look at the results of and what we know of best practices in teaching in general from the educational psychology literature and from the cognitive psychology literature. So, and then they were international, but most of them were in North America. I think 9 out of the 20 were in North America. And of them, the positive outcomes showed in online simulation and integrated curriculum. And then they broke them down by strategy. So I'd like to see if we could talk about each of these strategies. And then if you're out there and you're listening, if you have anything you would like to add in terms of what you feel about some of these strategies and how these have been judged in this article, some of the conclusions that were made, we'd like to hear that. So just type into the chat area or pose a question. So each strategy, let's start with, so let me just list the strategies. Online/blended, which is a hybrid. Essentially, they're all online, but they're called, when you call something a hybrid, that's considered online learning. Then the second strategy is traditional lecture. The third is flipped classroom. The fourth is problem-based or cooperative. The fifth is simulation. And then finally, they looked at something a little different. It actually isn't like the others are different ways of presenting material. The integrated versus standalone can be done in any of the other platforms, but whether or not you actually integrate pharmacology throughout your curriculum or whether you have a standalone pharmacology presentation, and that was compared as well. And again, the positive outcomes were seen mostly in the online simulation and integrated curriculum. So any surprises for you guys, given that flipped classroom and online, or actually online came out as a cooperative learning and problem-based have been promoted?
I was surprised that online learning had better outcomes, and but it was limited in scope sometimes. So in one of the studies, the online showed better results for at-risk learners, and so maybe in that case it was better for them because they could replay things that they didn't understand. And I was equally surprised that flipped Flipped had better scores in some of the midpoint evaluations, but not on final exams. And so, since that's such an active learning approach, I was a little bit surprised that wasn't higher, didn't perform better. But I think also that flipped classroom is just like anything else. With all of these things, there are so many variables there that, you kind of have to take that in context as well.
Yeah.
Yeah, and I think you bring up the good point. This is where is how good is the educator with that particular technique, and even with online, how good is the online stuff that they're doing? I still think my bias is I don't think there's been any strong studies that have proven beyond a reasonable doubt that online is better than in classroom. I'm more of a blended. I think there's a role for integrator, however you want to say, for all different mediums to be utilized to cover different topic areas, but there still needs to be that pulling it all together that takes place. But I still think it depends on the capabilities of the educator in the classroom.
Yeah, and so within the online or blended learning, there was only one multi-site that did a pre and post test, but it was e-learning versus face-to-face. And like Bill said, e-learning, that suggests to me that it's asynchronous. So that suggests to me that you are plopping down and doing I don't know if that's true, but when I hear that, that's what I think of. Whereas you can now, especially now with Zoom and with other platforms, you can have live lessons. You can have that, and then they can be recorded. And there's a difference between watching a live lesson where there's, you know, people asking questions and students in little squares, you know, that you can see, versus and participating in that, versus just being presented with something that's kind of flat and in front of you. And then we also don't know, what is the e-learning? Is it, you know, more PowerPoint word slides, which we know is not a good educational practice all the time, or is it like the heart code AHA, where you've got avatars and doing, you know, you're actually selecting treatments and doing that kind of thing and failing, and you know, not that I've done that in PALS or anything, but yeah, you know, where you're actually interacting with avatars and that kind of thing. So the quality of it is something that's, the quality of the actual educational piece is important. So that was only one multi-site, but they had higher scores with face-to-face in that study. The 7 others showed significantly higher scores with online or blended format. And that, interestingly, this is the one highlight of that little section on online and blended learning, is that they showed better in the procedural skills. If you watched a video and watch videos on demonstrations of procedural skills, higher scores not only on the skills but in communication as well. And that was in 7 other studies that showed positive effects here. So that was, go ahead.
You know, so some of that's probably attributed to the fact that when they're seeing the video of the skill, it's a standardized thing, and I think probably most of us struggle with having adjuncts demonstrate skills and having variability amongst them, and particularly this is nursing students, but at our entry-level students, they really need standardization to really be able to master those skills in the beginning.
Yeah, and John Friesen posts, and we see some questions here or comments here from Eric Martins. Nice to hear from you, so thanks for typing in. And Eric said he's getting some ideas just listening, which is great. That's what we want. And then John asked, did they elaborate on examples of what online simulation entails? And I only a little bit here and there, the online, that's kind of what I was mentioning. We don't know what the e-learning was, so that might make a difference, because we know that best practices are embedded in all types of platforms. So like we said, you can just throw a bunch of words into slides and have people watch something and click through it, or you can have them, you know, we know that retrieval practice is good, not just rereading or restudying, so we'd like to test people as they're doing an online you know, so they have to go in and retrieve information from the text or from sources. We don't know anything about those. So that's one of the things that's really hard to make a judgment about whether online learning is better or hybrid or whatever, just based upon looking at this overall. The other thing Doug Richardson asks, and I'm sorry, Doug, I'm unfamiliar with this, but what was the online a F3 type or F5? And sounds like that's a translation level. It can. Do you know? Are you familiar with that terminology, F3 or F5, except for tornadoes?
No, I'm from Missouri, so that means tornado when I hear it. Sorry.
No,
there we go.
They're talking.
Thanks, Doug.
He's talking
synchronous versus asynchronous.
Yeah, I was about to say, and that's the KHEP, not KHEP, but. I know them. I remember them as CISBEAMs, but the organization that deals with the kind of delivery of education that you're doing, and they use an F1, 2, 3, 4, 5, and stuff too. Yes, whatever you just said.
I learn something new every day. Thank you, Doug, for teaching us that, or teaching me that. F3 and F5. It's not just a tornado. Okay, so Charles Lee Miller says he thinks many of us learn pharmacology with rote memorization techniques like drug cards, in addition to a classroom experience. Did any of the studies review or account for student behavior requirements, and if so, which approach would have been categorized as? He's a nurse and a paramedic and works as an educator for both groups, which is really interesting, original and continuing education. So it's a good topic for review. So this is great. So we really don't know a whole lot of detail, but there were some. There was also another category the next category of traditional lecture. And this, there were only a few studies here that showed lecture versus small group and increased scores on calculation, drug calculations in the lecture group. And then one that showed, there were 5 studies that compared traditional lecture, and most of it was either lecture versus small group or electronic delivery, meaning e-learning over traditional lecture. And 3 of them showed a benefit of e-learning over traditional lecture. And again, we don't know any details about that e-learning. The one showed mixed results, and the other said lecture versus small group showed increased scores on drug calculations in the lecture group. But the student satisfaction, and incidentally on the online and blended learning, the student satisfaction was mixed. The traditional lecture, the students were less satisfied with than small group interaction or electronic delivery. So when it came to student satisfaction, we saw that. I think that's pretty consistent. I think, especially these days, I really think that, with the ability for students to look things up so quickly, and with, the free online access medical education, traditional lecture is really becoming antiquated. But again, what type of lecture? Is it interactive? Do you have interactivity during this quote lecture? What is lecture anymore?
I think that sort of speaks to one of the way the material is presented, the limitations of that. There's just not very much detail, so without pulling each of those, unfortunately, it's difficult to know, kind of, like you said, the quality. You can have good or bad in any kind of delivery system.
Exactly. We don't know the length of the lecture. Was the lecture an hour long? Were they TED Talks? What conference is that? Eagles, where they present these short little snippets of information and then move on to the next one. So we don't know too much about that. And we know that embedded in traditional lecture, there are best practices too, like, short interactive and interspersing things like retrieval practice right in the middle of a lecture at say 15 or 20 minutes in. You start putting up little quiz questions in your PowerPoints or a Kahoot or something that's interactive. And that can mean the traditional lecture, quote, traditional lecture becomes more interactive and more aligned with best practices. So then the third one, and this one I was kind of hoping Dave would be on for this one because I know he would have an opinion about it, but we know that David is traveling, so good, happy travels and safe travels to David Page out there. But the flipped classroom was the next topic. And the biggest thing about this was that there were only 2 studies that were looked at. And again, think about the years. This was 2000 to 2017. Flipped classroom is a relatively new thing. I'm certain it's pretty new in nursing education. And really there were only 2 studies. They had mixed results with, and Kim, you and I were talking about this, with increasing scores at the midterm, significantly different scores at the midterm exam with favoring the flipped classroom model, but then no difference on the final exam with the flipped classroom model. And then I think the thing I was most surprised about in that one was the student satisfaction was mixed. And they mentioned, I find this ironic, so I know, Bill, you're going to have an opinion on this, but the student satisfaction results in the flipped classroom talked about competing time with all of the other things in life. But why does that matter in a flipped classroom more than another classroom? So what does that say about just kind of education in general? Why wouldn't competing time not matter? Why the flipped classroom?
I think it, as well as I do, it matters in all of education. And I think there is this satisfaction that people are looking to achieve. At least my bias, and I always like to say this as it relates to EMS, how quickly can I obtain the certification that requires the least amount of my time and money so I can go and get a job and start making money? Yeah. And I think that when people sometimes look at what is it going to take to become a physician, how long does that take out of my life and everything? And any of the the higher level healthcare positions that take time, it takes a real big commitment of your time and effort to do that. And I think that's why we may be, and I'll stick this in here now because it sort of fits, at least in my mind, is that why there's a pushback, or we're seeing a resistance to even the concept of degree requirements for paramedics.
Yeah, and go ahead, Kim. Were you going to say something?
Oh, I was just going to say that I think that, just to add on to that, like there's this, Paulo Freire has this banking model of education, and a lot of the traditional education system is that way, where students just expect us to they want to be like little baby birds, where their mouths are open in the nest, and we're just going to drop the information into their mouths, and they feel like magically they're going to get it. And so when they have to really participate in active learning at home on their own, that's uncomfortable for some of them, and they're not used to budgeting the time to do that, because some people that, some students put in a lot of time no matter what, but some students are like, well, I'm not even going to read the book anymore. I'm just going to show up, and whatever the instructor says must be the most important thing. And so I think it's going to take a kind of a whole sea change to get people to understand that they have to own. I think in paramedic class we see that a lot. People come in and they're just not prepared for the amount of work and preparation that they have to do to be successful. So that's my little diatribe there.
Yeah,
I like that. I just want to say, when I did my doctoral program, that's what I found even with my classmates, is they almost went in there and were expecting the professors to open our minds and dump knowledge into it. And there was that culture shock where the professor says, no, that's not the way it works.
Yeah, and you're getting a lot of agreement online too. We're getting the baby bird example, no doubt. And Kim, yes, lots of agreement from educators out there. If you have not read Paulo Freire, there is a number of books. I can't remember his initial book title, but talks about the banking model. And it's an important topic, and this whole idea that you're going to open their heads and pour stuff in. And then I think sometimes we get spoiled. I know for me, I was spoiled with a class that was very involved and very engaged in the foam and foam ed kind of movement, and very interactive with that, and bringing stuff to class that I was learning so much about. And then occasionally you get some other groups that just are not that way, and it's they're individuals, but there is sort of a group dynamic too that can happen, and where it's kind of shocking, where you're just like, oh wow, I have to provide these for them, but they also have to engage in them as well. And Mark also says that the flipped requires a lot more outside of classroom time, and that's really the big thing. And Narina, hi Narina. So she says also true, both in EMS and nursing, don't want to invest the time to participative involvement in a flipped classroom. So. And that's kind of worrisome, because, again, we don't want to be just inclusive of people who will do well within certain environments. So it's a tough one. But in this study, getting back to this study, there was only 2 studies on flipped classroom, because I really don't think we've had the chance to look at that. And we have a couple of ongoing researchers in EMS that are very excited about and really moving and have been publishing abstracts, at least at this point, and moving to the next step of a paper looking at a flipped classroom model in EMT, and at the EMT level, I believe. So then the next one was problem-based and cooperative learning, which I remember when that sort of started to rise, this whole idea of let's get people into small groups and get them, solving problems together using case-based learning or whatever. But there's lots of ways to do problem-based learning, so that's sort of a generic term, and cooperative learning. And the 3 articles that they reviewed, only one was empirical research, and compared traditional lecture to cooperative learning strategies, and found traditional lecture to be favorable in terms of their outcomes which again were moderate level or low level outcomes. And then finally, the simulation, and it's not finally, there's one more, but simulation, I thought that was the most interesting area myself, and my bias is showing right there because I'm a big fan of simulation-based education. There were 4 quasi-experimental studies. Only one had a control group, but this was a pretty big study. It had 79 students per group. It was controlled lecture versus simulation. There were 3 rotations, 4 students in low fidelity simulation groups, and the simulation was significantly showed statistical significance and higher scores on the exam. Then there were 3 studies that were pre-post test design, which is a real kind of low level outcome, just pre-test and then your investigation and then post test. And one of them showed a long-term, a 6-month effect, positive effect of simulation versus a traditional lecture. So simulation in general was positive around, but they also very quickly brought up something that I think is going to be really important, and that's the whole idea of gaming and virtual reality and augmented reality. And we start seeing some of that come to, I'm not sure it's really realized yet, but the idea of using more interactivity and especially augmented reality where you actually get some feedback on what you're doing, that holds some promise as well. So what did you think of the simulation section?
This is Kim. I just wanted to point out that it was low fidelity simulation, and it still had a statistically significant effect, which I think sort of speaks to bringing in emotion into learning and what a positive effect that can have, and also when you do simulation, how it can really sort of sort out the little details, and it kind of brings to life things like side effects and positive effects of drugs and that sort of thing that might sort of embed themselves better in a student's brain. So I love that it was low fidelity, because some people feel like, oh, I can't do simulation, but this is a perfect example of why it does work, even if you don't have all the fancy tools.
Yeah, that's a great point. And I don't know exactly what they meant by low fidelity, but I have an idea, that the kind of more lower cost may be targeted toward a single simulation, maybe even standardized patients. So that would be interesting to look at that a little deeper sometime. I know, Kim, you've looked at the super study. Actually, can you just briefly, in case there are those out there who don't know the results of the super study, could you briefly mention that study and what it was about?
It was a study that we did through NIMSI that just looked generically at simulation use in accredited paramedic programs. And, probably the biggest finding was not so much a surprise to everybody, was that people who had simulation assets were not really using them. And people weren't using them to their fullest potential. And I think we did that before Portfolio came out. And I would love to be able to repeat that after Portfolio, because I think the Portfolio from the registry might have sort of pushed some programs that weren't doing as much simulation to do a little bit more and really understand why having people actually draw up the medications makes a difference. And so that's, in a nutshell, that's that.
Yeah, that was, if you haven't looked it up out there, the super study, that was just a great way of pointing out what, again, you might suspect something, but when you go out and actually research it, you can be surprised by results sometimes. The last section in here is, and this was actually my favorite, which was the integrated versus standalone, because this feeds right into educational psychology and the cognitive psychology that we've talked about in this podcast before, on blocking your curriculum versus interleaving. We've talked about spaced practice. We've talked about a number of different things. And one of those has been blocking versus interleaving, whether you present something in chunks and then you test on it, or whether you interleave it, you mix things in and then test. And overall, from educational psychology, we know that interleaving actually produces better results in the long term, meaning that the retention is much better if you interleave. And I think we've used the example on this podcast of EKG interpretation. We typically teach it in a blocked fashion. You learn sinus dysrhythmias and atrial dysrhythmias and junctionals and segments. And rather than that, if you interleaved throughout, the different types of dysrhythmias, interleaving is supposed to enhance your ability to differentiate between things rather than looking at similarities. So it tends to be associated with better retention. And that's, I think, what I got from their section here in the integrated versus standalone. They looked at, there were only two studies that they really looked at. So that's not a lot, but they were pretty high level. One of them, Meacham, used a patient case study and a short answer questionnaire that was like 70 items, an online test that was like 40 items, and then they explored principles of pharmacology and pharmacotherapy, a self-assessment of confidence, and then another study, Zellner, looked at outcomes on a pharmacology exam. And both of them found that integrated curriculum showed a statistically significant superiority in knowledge of pharmacokinetic principles. And this was one of the studies, Meacham was one of the studies where they applied it to the knowledge of a patient case. And then they applied it to patient education, so practice, and didn't see a difference. But the thing I liked about this was the results of this were very consistent with what we see in blocking versus interleaving, especially when you go to ask the students, because the students usually they like blocking better. It feels better. It feels more like they've learned in, I think, primary school. But interleaving shows better results in the long term. And they showed the same thing, where the students were not as comfortable with the integrated curriculum, even though their scores were better if they had the integrated curriculum. So I thought that was an interesting thing, and I thought that was pretty consistent with other research on undergraduate satisfaction versus how they actually perform. So I think there was a big study by, I believe it was McCabe. I don't know if anybody ever listens to out there, but there's a podcast, the Learning Scientists podcast, and they have a website, and they do a lot of, summarizing of educational research and cognitive science. And they frequently revisit things like spaced versus space practice, and then interleaving versus blocking, and retrieval practice, and things that are best practices. And they highlighted, they commonly refer to this study, I think it was McCabe in 2011, big study on undergraduate students and how they felt about their education and which types of educational practices they felt enhanced their learning. And then they compared that to what we know about what enhances learning. And they commonly select the strategy that will not enhance their learning. It's more comfortable to them, but it actually doesn't show good retention and long-term learning. So I think that was even though there was only a couple of studies in there, they were higher level, and they actually were consistent with what we see in educational psychology. I'd be curious to see, how many have an integrated curriculum and what we mean by that too.
This highlights to me, what you're talking about really highlights to me is that those of us that are in positions of educating, whether it be primary or continuing education, how important our education is because do we really know what we're doing or not doing in the classroom? Do we understand what are some of the best practices and most effective thing? I've always feel that sometimes the weakest link in EMS is the fact that we don't have a very well-structured, well-grounded process to develop EMS educators. And I don't think the development is just taking a course. There's more to it than just taking a 2-week course and stuff. And a saying that I often share with people is think that I can teach someone how to do front of neck access, but I'm not qualified to be in the kindergarten classroom.
Yeah. We brought this up the last time. And Dave really lit a fire in the audience by saying, yeah, of course, yeah, I can teach. I've got a hurt shoulder, and that's all I really need, right? I can go into training now. My shoulders hurt, so I need to do something. So they can just put me in training because everyone can everyone can teach. And you've gotten a lot of agreement online, Bill, from folks saying, yeah, it's not just a quick course. And I think that's the nice part about doing this podcast and having NEMC and the conference and a network of educators and integrating research into this and discussing it, so we can start this this conversation and keep it going. So we have a couple more minutes, and I want to know if you guys have any comments on the future of educational research, because I put a few notes here about what the future of educational research should be, and related to our own fields. So the authors here conclude that we need not just quasi-experimental designs, we need higher level outcomes and higher level research. And the crossover design, I think it's important for people to understand the crossover is to allow everyone to be able to experience the intervention. If you feel an intervention is better, at some point your controls should be able to cross over into the experimental group, especially if you feel that and that's an ethical consideration. And then, just a more multiple site research, and then a focus not just on calculations, but on knowledge base and pharmacotherapeutics, not just medical calculations. And if there is a medical calculation component, then the idea of mathematical skills, and integrating basic mathematical skills into the curriculum.
Yeah, I think that there are a lot of, you just posed a lot of questions, but I think we have focused a lot on calculation skills. And if you look at some of the studies that have been done out there, a lot of them focus on calculation skills. But they also have identified in some of the studies that some of them are protocol related and wrong route rate related, and like you mentioned earlier, conceptual errors that have been made. And so I think by using multimodal education, you're going to be able to get to some of those things. So I think that there's a danger in just saying that this one thing worked, this one simulation worked for this or lecture worked for this. I think all of us would probably agree that because one strategy might be more effective to teach one part of pharmacology than another, that we need to be multimodal in our education and offer the education in multiple ways for learning preferences and also just for that transfer of learning.
Yeah, and I want to just bring up something that Bill mentioned earlier, and then I know he can maybe give the example he gave earlier before we came on to the broadcast. And that is, at some point we've got to ask too and make sure we understand what is a medical error. So what is a medication error? So
yeah, and it's a shame, we're touching at this at the very end of the thing, because this could be a whole thing. And if we want to talk, in the example I used earlier, but also someone else gave, if I calculate that I'm supposed to give 0.3 cc's, but I give 0.4 cc's, does that really make a difference? Does it cause harm? And we also need to position ourselves well to answer the question when someone says, well, so what, I gave the wrong med or the wrong dose, the person was in cardiac arrest, they were already dead. So we need to move beyond that. And Kim even gave the example, this is, or you did, Megan, what we talked about before, is the intubation was successful. So what if it took us, 5 attempts and 15 minutes to do it? And the related trauma and everything that goes along with it. So we do need to find a way to even come to consensus on that. And then Kim brought up the concept of what is the role of just culture within an organization and practice and stuff. And so we have plenty of work to do. And so we need a young new workforce to take over and continue our growth and professionalization that comes with answering these questions.
What a great segue into Narina's comment, and we're going to leave it with this and an invitation for next time. But Narina says, I believe until we see EMS as a health profession and educate ourselves in the same manner as a collegiate level with a minimum degree, things will not change. We need to insist on college-level admission requirements, A&P, pharm courses, separate from the EMS curriculum, and will remain technicians instead of healthcare professionals. So yeah, and Doug says stating that not giving a medication when needed is a med error can start an argument. Yeah, and that's what we were discussing it before we even started, and that was that you know, it's not enough to say the end, and we're not agreeing with that. We're saying that we've got to stand down. We got to stand on those arguments where and face them when someone says the end justifies the means, and we know different. And when someone goes to give a medication, they intend to give one dose and they accidentally give another. That's an error, regardless of what happens to the patient. So that's what we were discussing before we came on here. So lots to do. We're really happy you joined us today, and we look forward to seeing you next time. So thanks again for everyone, and thanks for Kim and Bill for joining us this morning. And the next Education Research podcast is Friday, March 22nd. We're going to be looking at retrieval practice. And I know we've discussed this before, but we've got a really good session waiting on this. It's a retrieval practice and Bloom's taxonomy. Do students need fact knowledge before higher order learning? And this is in the American Psychological Association 2018. You can also join us too, Monday, March 11th, the Clinical Podcast, 10 a.m. Pacific, noon Central Time. So thanks you all for joining us, and we'll see you next time.
Thanks, Megan.
Thanks, you guys.